This episode of Med Surg Moments was made possible by Medtronic. For 70 years, Medtronic has been utilizing the power of medical technology to improve lives. Visit their website at www.medtronic.com. This is Caroline, and I welcome you to this episode of Med Surg Moments, the AMSN podcast. This podcast is an engaging look at the lives of and surrounding medical surgical nurses. According to Medtronic's PRODIGY Study, 46% of patients receiving opioids on the general care floor experience respiratory depression. These common episodes are costly for both patients and the hospital, often extending the patient's length of stay. For these reasons, as well as AMSN's own commitment to opioid patient safety, we have partnered with Medtronic in a key collaborative effort to address the opioid crisis and keep patients safe. Here with us today for a conversation about the PRODIGY research and how med-surg nurses can help reduce respiratory depression in high-risk patients is Dr. Carla Jungquist. Dr. Jungquist is an associate professor at the University of Buffalo and a nurse practitioner at the University of Rochester Thompson Health Sleep Disorders Center. She has over 40 peer-reviewed publications in the area of sleep and pain and has received funding from the CDC, the NIH, and the industry for her research program that focuses on the relationship of sleep, pain, and improving patient safety with opioid medications. She served as Buffalo site investigator for the Medtronic-sponsored PRODIGY Study. And so it's my great pleasure to welcome you, Dr. Jungquist, to this special episode of Med Surg Moments. How are you today?
I'm very good. How are you?
Doing great. Thank you. This is a really unique episode, but I think something that we will all be able to relate to as med-surg nurses. Before we get into your study and the results and the outcomes, let's begin with your own nursing story. Why did you become a nurse?
Carolyn, first I want to thank all those med-surg nurses out there for taking such good care of our patients. And I want to thank you for your opening up this conversation so we can chat about a very important topic that I'm pretty passionate about, and that's patient safety with opioids, especially on the med-surg units. So my nursing career was spurred by the care of my grandparents a long time ago as an adolescent. So taking care of them at the end of their lives, it was very rewarding. I started my career as a critical care nurse where I saw many opioid overdoses, young kids, mostly with heroin at that time. I then moved into community health nursing where I provided care for patients who were HIV positive, and most of those moved into a full-blown AIDS very quickly. Most were patients with histories or had current addictions to heroin. Once I completed my nurse practitioner program, I moved into the medical care of patients with addiction and mental illness. And I was there for a few years until I moved in to a chronic pain clinic, and I was there for about 15 years. So my career really has been all about opioids and really understanding what opioids can do to the body, understanding addiction, and understanding how we can best care for patients that have a chronic and acute pain. Well, this interest of mine moved me forward to get my PhD degree. And then I moved into sleep practice because I really wanted to know more about breathing and the effects that opioids have on breathing. So my research program began there. I really want to share a patient story because that seems to really hit with us nurses. These patient stories really inspire us to continue in our careers, and it takes great dedication to continue in a nursing career. So I was working at the VA at a chronic pain clinic, and I had a patient who was on really high doses of opioids. He wasn't a larger guy. He was in a wheelchair, but with the opioids, he was able to get out of the wheelchair and be a little functional at home. No depression. He really was a really sweet guy who respected the amount of opioids that he was on. He ended up in the hospital with a pneumonia. And I got a call from the primary care provider in the community. He yelled at me. He told me I was killing his patient from prescribing those opioids. This was in the late 1990s when opioids for chronic pain were prescribed just as they were for a cancer patient. Those were the days back then that started this whole escalation of problems with opioids. I thought I was doing a good thing. These large doses were assumed safe as we believe that tolerance to respiratory depressive effects develop over time, like they do for the cancer patients, and we really wouldn't have to worry about breathing. So I thought, I'm going to prove this doctor wrong. So what I did is I went to the literature and I thought, okay, I'm going to find that evidence that respiratory depression effects of opioids in patients that have chronic pain and are on them long term, that it dissipates over time, that it's not a problem. So I was in my PhD program and my research was all about opioid-induced respiratory depression. And basically I found there wasn't any evidence. We were prescribing huge doses for chronic pain, and it really was not evidence-based. So I thought, okay, I really got to learn more about these breathing issues with opioids. So I recruited a whole bunch of patients that were going to a sleep disorder center for evaluation. And all of them were on opioids that I looked at their data. And what I found in this research was that people who were on long-term opioids continued to have a respiratory depressive effect at doses higher than 100 morphine milliequivalents a day. Sometimes I wish I wouldn't have done that research, but it really was.
Yeah, wow. Wow.
Yeah, it really proved that these high doses of opioids, the respiratory depressive effects really don't completely happen. There is a residual respiratory depressive effect. My research now is all about alerting nurses on the continued problem of opioid-induced respiratory depression and how can we prevent harm from happening. So going back to that patient, he did fine. He was discharged from the hospital. I actually did wean him down some from the opioids, and he was weaned down to around 100 milligrams. And last I knew, I had left that practice, but last I knew he was doing fine.
Wow, what an interesting story. From piquing your initial interest to making that discovery. That's fascinating. It really is. Wow. And sharing your story about nursing as well. Thank you. It's not an uncommon story where people are impacted by a family event to want to carry on and join the profession. That's wonderful. So for our listeners out there, first of all, can we take it back a little bit? And what would be your textbook definition of what respiratory compromise is all about? In the Med Surg, we have these wonderful little expressions. In my world, what I used to remember was less than 8 intubate. We've got to get this patient transferred to a higher level of care. So how would you define respiratory compromise?
So respiratory compromise is a term that really speaks to the state where a patient is experiencing difficulty maintaining ventilation. And I really want to talk about ventilation versus oxygenation. I think nurses don't necessarily differentiate the two. So let me go into that a little bit further. So we all learned in nursing school about how to measure ventilation. And there are many causes of respiratory compromise, or you could call it respiratory insufficiency. But in each case, the body's ability to oxygenate and exhale their carbon dioxide is altered. So ventilation involves the delivery system that presents oxygen-rich air to the alveoli, whereas oxygenation is really the process of delivering the oxygen from the alveoli to the tissues that maintain cellular activity. So to adequately assess ventilation, you must measure respiratory rate with oxygen saturation, or you can measure carbon dioxide. And on a Med Surg unit, carbon dioxide is measured by a CO2 or capnography, or more recently, there's transcutaneous carbon dioxide measurement. Have you heard of that at all, the transcutaneous?
A little bit. It's gaining momentum, certainly. Doesn't have a huge presence in the area that I'm at, but I have read a little bit about it. Yes, definitely.
They used it in the OR originally, but then it went into the PACU and now is getting into general med surg care. And it really is just wearing a lead on the cheek. It's up and coming, but it's not mainstream. And nurses need something to measure ventilation that's really mainstream. So we've got to stick with capnography and tidal CO2. And I know it's a little intimidating to some med surg nurses. So we can talk about that a little bit more too, if you want to.
Sure. One of the reasons we're doing this topic right now is because October has actually been named Opioid Awareness Month. And so it's really important to connect with what you're talking about, the transcutaneous measurement, capnography, and tidal, because as med surg nurses, we're aware that there's a crisis. We don't necessarily understand perhaps the full and complete reason behind it, but what we're faced with are patients on the floor that are not breathing. And then that's a problem, obviously. Why are patients receiving opioids, why are they at a higher risk for respiratory compromise, without stating the obvious, so that it depresses the respiratory system? Is there anything more physiological that you think our med surg nurses should know about there?
So when we administer a dose of opioid, the medication depresses the breathing center in the brain and thus impacts actual ventilation. When ventilation is depressed, oxygen levels will dip down. So you must remember that an assessment for respiratory compromise, you've really got to look at ventilation, because that's going to be the earlier sign of respiratory compromise as compared to just oxygenation. Measuring oxygenation is just a little bit of a later sign of respiratory insufficiency. So not all patients are sensitive to the respiratory depressive effects of opioids. And we know that because the largest percentage of our patients do absolutely fine. We give them opioids, their pain is well controlled, their function increases, they go about their business of recovery, get home and do fine. But we need to figure out who are those that are not going to. And I just don't want to hear one more scenario of dead in bed. That ends nursing careers. It really is such a challenge for nurses. So not all patients are sensitive to the depressive effects of opioids. So as we know from our practices, patients can take really high doses of opioids and they just keep ventilating just fine, while others will get into trouble. We know that genetics plays a role, but that evidence is very underdeveloped. Testing is not currently clinically available for most of our patients. So nurses have really got to know how to identify that patient that's at highest risk. And this is really important for patient safety. My professional organization that I work most closely with is the American Society for Pain Management Nursing, or ASPMN. So ASPMN sponsored a group of experts to develop evidence-based guidelines for monitoring inpatients for opioid-induced respiratory depression. And you can go to the ASPMN website and you can find these guidelines and download them, or you can go to PubMed and search my name and you'll find the publication, because I was the lead author on that publication. So these guidelines provide the standards of care for assessment of the high-risk patient and best practices for monitoring to ensure patient safety with opioids on the Med Surg units.
Can you elaborate a little bit more about the PRODIGY study and what we've learned from that, with the end goal, of course, keeping our patients safe, managing their pain effectively, but allowing them to have good oxygenation and ventilation at the same time?
That's definitely the goal. We want to keep them breathing. Yeah. We want to keep them comfortable, and we want to keep them out of bed and going and contributing to their rehabilitation.
Yeah, tie in the evidence here. Med surg nurses love that evidence-based practice, and I think they'd be really interested to hear a little bit more about your research.
So the folks at Medtronic, who I really respect for doing this, recognize that adverse events from opioid-induced respiratory depression are still a problem. So a few years ago, they looked at the data and they said, wow, up to 4.2% of patients that are in the hospital will have some type of an adverse opioid event, whether it be just needing to be rescued by the nurse shaking them a little bit, or having their opioid dose reduced, but still a problem. Patients who have an event or experience some respiratory difficulty from opioids have longer hospital stays, increased patient burden, increased healthcare costs, increased risk for 30-day readmission. And there's a 3.4 times higher risk of inpatient mortality in these patients who have experienced some opioid-induced respiratory depression.
Okay, so you have my attention.
Yeah, really.
Yeah.
Well, in hospitals, they attend to this because what the research has shown is that each claim for patient harm up to $2.5 million per claim.
Wow.
So hospitals, they don't want to go into the legal field with a bad patient event. When something bad happens on your watch, it can cause nurse burnout and nurses to leave the field. And so we've got to do everything we can to support our nurses so bad things don't happen to our patients or our nurses. So Medtronic recognized this, and on units where all patients are monitored using capnography or oximetry, another problem is alarm fatigue. What direction do I go in? There's so many alarms going off. We have bed alarms, we have the TPN alarms, IV alarms, capnography alarms, oximetry alarms. That alarm fatigue is a real problem. Medtronic recognized that. They don't want to put out the message, every single patient has to be monitored. That's not really feasible. And it causes alarm fatigue and contributes to nurse burnout also. So a group of clinicians developed a study to establish a tool that could be used by the healthcare team to identify patients who are at higher risk. The team enrolled 1,495 hospitalized patients at 16 sites in the US, Europe, and Asia. All patients were administered opioids for acute pain, whether on a medical unit or a surgical unit, and all patients wore a device that measured end-tidal CO2, oxygen saturation, pulse rate, and respiratory rate. So we collected a bunch of data on these patients. It was demographic data. We collect data on adverse events, if they happened, what medications they were on, the timing of their opioid delivery. And there was an independent group of clinicians that read all the monitoring data. So these patients were monitored for somewhere between 24 and 48 hours after the point of them starting the opioid. So we had the patients that were opioid naive and some of them who weren't opioid naive. It was a really huge undertaking. But what happened was these scientists took all the monitoring data and they visually looked at it. And they determined when there was an episode that was an opioid-induced episode. So the episode was defined as a respiratory rate of less than 5 for 3 minutes, an SpO2, so an oxygen saturation equal to or less than 85 for 3 minutes.
Okay.
End-tidal CO2 that dropped less than 15 or went greater than 60 for a 3-minute period, or a complete apneic, no breath at all, for 30 seconds. So the episodes were defined by those parameters. You can see that these thresholds actually were very conservative. I mean, a respiratory rate at 5 for 3 minutes.
Yeah, that's
quite
scary.
a lot. Yeah. At that point, nurses like, whoa, breathe.
Yeah, exactly.
So they were really clinically relevant episodes that were defined by these clinicians who read the monitoring data. So luckily, most of these patients self-rescued, as most of our patients will. They will meet that threshold of their CO2 climbing, and they'll take a deep breath and they'll continue to breathe.
Right.
But 614 of our over 1,000 patients that we enrolled experienced at least one of these episodes. So that's 46% of the patients that we enrolled had at least one episode of opioid-induced respiratory depression.
Wow.
Yeah.
I would say that was clinically significant. Yeah. And a little alarming.
We were surprised that the number was so high. But I can tell you that I have done different studies in the PACU and Med Surg units where I looked at similar data in a whole different set of patients. I too came up with a number of 42% of patients will develop some respiratory related event after taking an opioid. So I completely believe that this is really clinically relevant data, solid data.
Most definitely. Let me take you not so much in a different direction, but bring in the fact that med-surg nurses are used to using some form of continuous monitoring. It may not be remote. Can you share a little bit with our listeners about remote continuous monitoring and how that might help improve on the episodes of apnea and the role in ensuring safe patient use of opioids? There's a recognized need in a certain population of patients. What can they do so that we can keep them safe?
Our statisticians analyzed the data, and what they found was the goal was to develop a tool that nurses could use to identify the patients who were at highest risk. So there were 46 potential predictors. The ones that were statistically significant were age, sex, being opioid naive, having obstructive sleep apnea or some type of history of sleep disordered breathing, or chronic heart failure. So we found that those were the highest predictors. So what the team did then was they developed the PRODIGY Risk Score tool. And it's now available, and it can be used clinically, although it needs to be validated a little bit more. It's been developed with some really good solid data. So basically the nurse or computer could actually do this. It would take each patient and score them on the potential risk factors that we found that would put a patient at highest risk, and classify the patient into either low risk, intermediate risk, or high risk using this tool. So if a patient was found to be at intermediate or high risk, then they should be put on continuous monitoring of their ventilation. Now, I can't reiterate this enough. We need to measure ventilation. And the two best ways to do that is to measure oxygen saturation plus respiratory rate, or end-tidal CO2, or the other way you could measure is transcutaneous, which is a newer technology that we haven't quite got to yet. But so we have to measure ventilation. Mm-hmm. So if you're using oxygen saturation, the other thing nurses need to think about is we've got a lot of these patients on supplemental oxygen. And if we're measuring oxygen saturation, often we aren't going to get an accurate measure of ventilation unless we're also looking at their respiratory rate or their CO2 level. You put somebody on supplemental oxygen, you'll see their oxygen saturation climb up really quickly, and it'll stay up there. But it doesn't mean that their CO2 level isn't always also climbing. So we need to measure ventilation.
Ventilation. Yeah, I think that's one of the key words we're going to take away from this podcast for sure. Good. And it makes perfect sense. Yeah.
So the question you asked, what can nurses do? That was a great question. And it's really interesting to understand the research and how we can apply this on the Med Surg units to make sure that we're providing evidence-based care for our patients to increase patient safety with opioids. So what I want to do is I want to go to the ASPMN monitoring guidelines. And I want to talk a little bit about what those recommendations are so that the med surg nurses can understand what the evidence has shown that we should be doing. Number one, all patients who receive opioids, regardless of route, meaning whether it's PO, IV, intrathecal, anybody that's taking an opioid has the potential to have a opioid-induced respiratory event. So all patients that are starting opioids should have a comprehensive assessment of individual risk using evidence-based screening tools like the PRODIGY tool prior to initiation of the opioid therapy. Then the next step is to think that all patients could be at risk. So we have to find out their risk, and then we have to develop a plan of care. And the plan of care should include patient-centric, opioid-sparing plans of care that are based on their risk, the patient's risk, and recognize that these plans of care may change over time. So we continuous monitoring for the first 24, 48 hours, and a patient's been in the hospital a long time. If their opioids aren't changing, their respiratory status has been stable, take them off the continuous monitoring. We don't want to tether patients to bed. That's not going to contribute to quick recoveries of having patients tethered to beds. So communication, that's a next recommendation. Communication is really important to all members of the patient care team. Using electronic alerts really helps. And I'll tell you a little scenario I've learned from my research. I've done quite a bit of research on identifying the patient at risk in the PACU. So these nurses are going to receive the patients onto the Med Surg unit. That PACU nurse has one-to-one the patient. They can see who is developing respiratory sensitivity to the opioids. They can see who didn't, who they had high doses of opioids in the PACU and their breathing just continued just fine. They need to really communicate to the med surg nurse, look, this is what I saw in the PACU. This patient is at higher risk. Put that continuous monitor on them. Put them closer to the nursing station. There's somebody who needs to be watched a little bit closer. So I think the PACU nurse really has a role in starting that chain of communication to the med surg nurse. Look, this is what I saw in the PACU. This patient is at higher risk. Put that continuous monitor on them. Put them closer to the nursing station. There's somebody who needs to be watched a little bit closer. So I think the PACU nurse really has a role in starting that chain of communication to the med surg nurses. So that said, just 3 more recommendations I want to talk about. It's up to the hospitals to develop policies and procedures, that they have educated the nurses on best practices, and that they're making sure that the nurses really can administer opioids safely. Assessment should be inclusive of level of sedation, respiratory rate and quality, and oxygen saturation prior to initiating the opioid therapy, before administering the opioid dose, and at peak effect. And just a little bit about PCAs. We can't tell when peak effect is because we don't know when a patient is self-injecting the opioid.
Right.
Yeah, we're not at the bedside. So they have to be continuously monitored. Anybody who's on a PCA should have continuous monitoring. And then once a patient is determined at immediate or higher risk, continuous monitoring should be on the patient for at least the first 48 hours, because we know that adverse events are most likely to occur in the first 48 hours. I'll go back to your question on what is remote monitoring. And what that just means is let's have the monitors at a central location or on the nurse, not at the bedside. The door gets closed to the patient room, and then we can't hear the monitor alarms. That's what best practices are and monitoring is.
So the whole scenario, the study, the recognition that opioids trigger respiratory depression is absolutely fascinating. I wish that we had another 30 minutes to talk about this. I do want to ask two more points in closing. The implementation of remote continuous monitoring obviously would be physician directed. Are there any barriers, perceived or real, with this implementation?
So instituting continuous monitoring really is the responsibility of the facility, the hospital, but nurses at the bedside, we have a large voice and we can advocate for that.
I'm so glad you said that. Great. I'm so glad you said that.
Well, the bottom line is always money. And hospitals need the evidence to go to the budgeters and say, look, this is an important thing that we need to invest in. So just a couple points. Remember I said earlier, one case can cost the hospital up to $2.5 million.
Yes. So
that's a factor. It's published. There's literature out there. A couple different studies have shown that. And there's also data from the PRODIGY study that continuous pulse oximetry and capnography monitoring on high-risk patients is projected to reduce annual hospital cost up to $535,000 and cumulative patient length of stay 103 days. That data came from the PRODIGY study. So there's a 1.5% reduction in respiratory depression events that could cause a break-even investment point and justify the investment cost. So I think the biggest barrier really is money. And there's evidence out there where the hospital facilities can, and the nurses even can get this information, and it's published. If you go on PubMed and put in my name, because I'm author of a lot of these PRODIGY publications, you're going to be able to find the PRODIGY studies. Great. If you go on the ASBMN website, you will be able to download the guidelines.
Perfect. It's good direction for our nurses as to where to go next. And like I said, a fascinating, eye-opening podcast. It truly has been a pleasure having you with us on this very important episode in the month of October. Thank you for sharing your time and your expertise. And I think you piqued a lot of interest for our Med Surg nurses to investigate a little bit more. Thank you so much.
You are very welcome, and your audience is welcome to contact me at my email address is Carla Jun, so CarlaJun @buffalo.edu.
Wonderful. Thank you so much.
You're very welcome. It's been a pleasure.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, your topic ideas, your feedback via our official Med Surg Moments email address, which is amsnpod@amsn.org. Once again, amsnpod@amsn.org. We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education. We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners. We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN in the search field on any of the social media platforms to connect with us. The content within Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Caroline. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that make a huge difference.